Great. Well, thank you so much for coming this afternoon, everyone. I'm Jane Barrow, the Executive Director for the Initiative to Integrate Oral Health and Medicine. And it is my absolute pleasure to welcome Dr. Lisa Simon to join us today to talk about exploring the impact of Medicare dental exclusion. Many of us have known Lisa for quite some time. Our relationship goes back to her student days. We worked on geriatric curriculum and on healthy initiative to integrate oral health through a mobile van. We worked on the national jail and incredible serving vulnerable populations throughout her time at HSDM, her time as a general practice resident, and throughout her time at HMS at the Brigham, where she is a resident in primary care. And we're just thrilled for involvement and our continued interest in how we achieve equity in overall health, including oral health, and very much look forward to hearing from Mark today about them. Thank you.
Thanks so much, Jane. Excited to be here. I have spent countless hours in this room. That was my preferred seat, was like that corner. And when I got really bored, my move was I would buy a muffin from the Courtyard Cafe and I would see how slowly I could eat it. So like, could I make it last like 4 hours? And the answer is yes. Anyway, super excited to talk to you guys. So this is some research that I co-authored with two researchers who are at the medical schools or East and Mike Barnett, who I'm deeply grateful for. And we'll just get started. This may be familiar to some of you. It's a little bit of a false start, but back in 2021, there was a lot of excitement, in part because, as you guys know, when dentistry makes the New York Times, like we're all aware of it. It doesn't happen too often, with the hope that Medicare might actually cover a dental benefit. And I'll just ask for a moment, can the participants in Zoom confirm that my mic is loud enough that they could hear? If someone could just like put a thumbs up in the chat or something, that would be really helpful. Hopefully that's a thumbs up. Thanks, Christina. And so going back to what happened after that New York Times article and what we can hope to accomplish in the future, I'm just going to give you a little bit of a roadmap about this particular research, but also hopefully with some fun historical detours. The first, why does Medicare lack a dental benefit? How we can study that and better understand it, and how we can advocate for one another. So why does Medicare lack a dental benefit? What we do know about Medicare is that for medicine itself, it is the closest thing we have to universal health care. There is a reason why when we talk about Medicare for all, we talk about Medicare. And there is excellent research that shows that getting this sort of universal health coverage absolutely benefits individuals and benefits society. It has led to important drivers of health policy change. It is associated with decreasing disparities in racial and ethnic identities. And it also benefits almost all beneficiaries over age 65 in terms of whether they're able to access preventive care, whether they're able to afford healthcare. Basically, everything we think about when we think about what good healthcare should be, Medicare achieves, except in dentistry, which, as many of you know, is entirely excluded from Medicare. And this comes back to the 1960s. So back in 1965, when Medicare was passed, there really wasn't a difference between medicine and dentistry. Both the American Medical Association and the American Dental Association unified in their opposition to Medicare, which created phenomenal memeable images like this first viral album, Ronald Reagan Speaks Out Against Socialized Medicine. Fun fact, the secret mission for the AMA and the ADA to dissuade people from Medicare was called Operation Coffee Cup. And that's because the goal was to get the wives of doctors and dentists, because there were no female doctors or dentists, to have meetings in their community and kind of like have a coffee clatch over how bad Medicare was. And this was like a secretly funded thing. So crazy stuff was happening. But the big emphasis is that it's not like dentistry was like doing one thing and medicine was doing another. Both didn't want to be a part of this, but medicine lost in some ways and dentistry won in some ways. And this is where we are now. So in 2018, only 53% of Medicare beneficiaries had a dental visit. Older adults are the group with the lowest rates of dental insurance of any demographic groups in the country. And for Medicare beneficiaries who do go to the dentist, the average out-of-pocket cost is $1,000. So overall, the cost of dentistry relative to the cost of, medical care in America per capita is much, much lower. But when you're thinking about older adults who are usually retired on a fixed income, this is much larger out-of-pocket expense than almost any other form of healthcare that they are seeking. It's essentially unaffordable. This may be familiar to especially Dean Ginobili, since this is from a paper that we co-wrote together. But just to give you a sense of what does dental insurance actually look like? And for those of you who maybe are in clinic right now, some of this is probably too familiar because you know very well what your patients are able to afford and not. But private dental insurance, not really insurance, right? It's not something that is designed to cover large or offset large expenses, but maybe it's like a discount plan. It might make something slightly cheaper, which could make it more affordable for an affordable. Medicaid, which is the public program for low-income people, is very generous here in Massachusetts, but is administered on the state level. And I'm sure you probably still have patients who can't get care they need with their Mass Health benefit. Traditional Medicare, which is what we talk about when we talk about Medicare, doesn't cover anything, right? And then there's something called Medicare Advantage. For those of you who are trainees in the room, have you guys heard of Medicare Advantage? A little bit? Cool. So Medicare Advantage, for those of you who don't remember back from health policy class, first years, is basically a privatized version of Medicare. So Medicare itself is like Part A and Part B and Part D, and like A is inpatient and B is outpatient and D is drugs. It all comes consolidated together into Medicare Advantage, which is administered by private insurance companies. There are some interesting issues with Medicare Advantage. You guys can think yourselves whether you think it's a good idea for part of Medicare to be entirely privatized and then the government giving that money to private insurers. But we don't really know what kind of dental benefits some of those groups might be getting. You may, again, remembering some of those terms from your first year health policy course, be thinking about whether having a dental benefit might potentially be some sort of adverse selection, which is to say, maybe it makes healthier people want to come join those Medicare Advantage plans and make money for the private insurers. But the important part is that it's really hard to know what they're actually offering. They may be offering something different than traditional Medicare. And I'm harping on this because it becomes really important to understanding our research outcomes. So how do all of these very complicated mechanisms for dental insurance, which let's remember isn't actually an insurance system for Medicare beneficiaries and older adults? And we did this with a quasi-experimental method and a large nationally representative survey. So MEPS is the Medical Expenditure Panel Survey. This is a really giant survey that is administered federally. It involves thousands and thousands of people that are deliberately chosen to represent the overall population of the United States. One of the things it does really excellently is that it oversamples groups that are underrepresented in survey research, which means that there can be meaningful conclusions drawn, especially about vulnerable identity groups that are otherwise poorly reflected in a lot of research data. It also asks questions about dental utilization, some of which I listed here. Complete edentialism, whether people have dental insurance, and even what dental visits they receive down to the dental codes. And then it's not just asking people this information, it's also confirming with their insurance company, with their employer to see what kind of insurance they have. It's really the only game in town when it comes to doing this kind of work on the federal level, thinking about people with all different kinds of insurance. But it's not perfect, and we'll talk more. The method we use to evaluate this is called regression discontinuity. It's a quasi-experimental model. And for those of you who are not as deeply embedded in health policy research, a quasi-experimental model is something that uses retrospective data like MEPS and uses methods that allow us to act like it's a natural experiment. So instead of doing the RCT, we can use a quasi-experimental method and still make causative conclusions with our data. Regression discontinuity looks at a jump across a particular discontinuity. In this case, Medicare is really excellent for this because most people qualify for Medicare exactly at age 65. You can draw that line in the sand really well. And you can assume that probably people who are 64 years, 11 months and 364 days are not that different than people that are 65 years and 1 day old, except that all of a sudden they qualify for Medicare. And then you can see what else is different about them and assume probably Medicare contributed. So for example, here is a regression discontinuity looking at change in medical insurance before and after age 65. And you can see that there's a really big jump right at 65, which is not surprising because people all of a sudden qualify for Medicare.
You get rid of the bar at the top, and there's an X there. I think you could.
Yeah, I would be happy to do that, especially right in the middle of the data.
Thank you.
There we go. Thank you for asking. And if anyone has other questions, please feel free to chime in. I would love to sort of dig in deep on that. And just to talk a little bit about ways to verify and actually appropriately conclude that the age 65 Medicare eligibility is causing the things we're looking at. We evaluated multiple different regressions. We looked at different ways of weighting the data. So a triangular kernel means that we preferentially said that people who were very close to 65 probably were more interesting to our data than people who were like 51 or 90. And we used a special tool that evaluated different ways of kind of slicing those people into groups before and after 65. And this is what we found, just to give an example. So one thing that's interesting here is that, remember, discontinuity is looking at the jump right at 65. There's a little bit of a jump, right, in terms of how many dental visits someone has, but there's also a really big change that's not reflected in any sort of immediate jump, right? The slopes completely change. They start going like a playground slide. So that requires something different to evaluate it. This is not something that the quasi-experimental method of regression discontinuity measures. So we also did what we called a segmented regression, which looks at a cutoff and changes in slope before and after, exactly like this. One thing that's important to note is that regression discontinuity is quasi-experimental. It means I can say, based on this model, it is reasonable to conclude that the jump at 65, i.e. being enrolled in Medicare, is the cause of this change. Segmented regression is observational. I can say that reaching age 65 is associated with a change in slope. I realize that that's like a really boring, wordy way to convey that, but it's important because I don't want to make a claim and be like, it's definitely because of Medicare, even if I think probably at least in part because of Medicare. So using our sample, we restricted only to MEPS respondents who were 50 to 85 years old. We excluded people who were actually at 65. So we gave kind of a donut hole of 1 year. And here's the important part where all of that boring talk at the top about Medicare Advantage becomes important. As it turns out, in the MEPS survey, which let's remember is literally an interview with thousands and thousands of people, they didn't actually ask people with Medicare or Medicaid if they had dental insurance. It's a fatal flaw in MEPS that the federal government is administering, which I think raises a lot of questions about how we think about oral health, how we measure oral health, the prioritization of oral health within medicine, lots of things to change. But it means that I can't tell you about changes in dental insurance because a whole big group of people didn't have that measured at all. But it means there are lots of interesting questions to think about, and we'll come back to that. So covariates, what other things could impact people's dental utilization? These are the ones we chose. And when I say a priori, it means we picked them in advance using our knowledge about oral health and risk factors for oral health utilization. We included age, we included gender identity, racial and ethnic identity, and then income as a percentage of the federal poverty level, and also retirement status, because even if you have more time, regardless of whether you're working or not, that might make a difference in whether you can go to the dentist. So here are our results. So there were 97,000 respondents from 2010 to 2019, so 10 years of data for those thousands of people. And when you weight those people to represent the actual population of the United States, it represents about 104 million, so a third population. And there were no significant changes in that jump, the regression discontinuity, for any of the demographics we cared about, our covariates, except for rate of employment, because obviously people at 65 are more likely to retire. And here's a graph showing prevalence of edentialism before and after Medicare eligibility. And there's actually about a 5% jump in complete edentialism at age 65. And this accounts for all of the covariates we discussed. We also clustered people's forms of dental utilization and looked at emergency dental care, preventive dental care, and restorative dental care. I think for most dentists, this is probably not surprising that emergency dental care didn't change, preventive didn't change, but restorative dental care had an 8.7 percentage point drop in utilization at age 65. The way I put this together is that emergency dental care is not optional. It's not cost sensitive because you have an emergency. You're going to have to go, unfortunately. Preventive dental care is relatively affordable. If people are getting it, they may be able to continue to afford getting it. If they're not getting it, it may not be a priority later. Restorative dental care is very cost sensitive, right? It's the stuff you're opting into. And it's often the stuff that is free or highly discounted from dental insurance plans. There's where we see the big drop because people are losing access to their insurance. This is looking at dental expenses covered by private insurance exclusively, because I think this gets to the question of what's happening. And unsurprisingly, there's a huge drop in the percent of dental expenses that are covered by private insurance, which adds up to this narrative that people are losing their private insurance or unenrolling from their private insurance at age 65, getting on Medicare and not having a dental benefit along with that. Here are some of the graphs where we looked at the segmented regressions, because the jump doesn't tell the whole story. Once someone's in Medicare, they've got another, just on average, about 25 years to access or not access dental care. So people continue to, you can see there's a rise in the percentage without teeth even after that jump. But then there's also these complete inversions of slope. Number of annual dental visits rises up to age 65 and begins to decrease. Annual dental expenses rises up to age 65 and then begins to decrease. And then percentage with a dental visit rises and begins to decrease. You can imagine that some of this is related to people becoming older in age, but at the same time, we accounted for that. So looking at these segmented regression models, we looked at before age 65, so this is the slope, after age 65, and then the percent change in slope. So like I mentioned, we see an increase until 65, and then all of a sudden a decrease. All of these slopes went from being positive to negative. And the percent changes are actually quite dramatic. So every year after someone is 65, there are 14 fewer dental visits per 1,000 beneficiaries. People spend $5 less per year every year after 65. And people have 0.52 percentage points less likelihood that they might have any dental visits. So I find these numbers extremely compelling. They kind of tell us something we might already suspect as dental professionals, which is that losing dental insurance and entering into a nationalized healthcare program that lacks dental coverage results in worse outcomes and lower dental utilization. I want to emphasize that this is not perfect. This is not a longitudinal survey. So we're not following the same person from age 50 to age 85. We're just looking at a big pool of people at various ages, snapshot in time. People may actually be in the labor market, but going from full to part-time hours, and maybe that affects their access to care. And again, we can't impute Medicaid or Medicare Advantage dental coverage because it's simply not asked. This is a fatal flaw in MEPS. But there are other ways to think about this. Yeah?
Dr. Simon, why don't you also do this study on Medicaid? Because if someone that's qualified for Medicaid before and after 65, you can also show that people's behavior doesn't change after they hire if they are given the opportunity to have their dental care paid for.
The challenge is that Medicaid may or may not have a dental benefit. It depends on the state. So this is a big national data set. You actually can do sort of what you're describing, looking at Medicaid data, but it requires getting the state level and knowing which year these benefits kick in, right? Like it gets really complicated when you leave it to the state. So you have to know like, oh, okay, so this person's in New Hampshire. New Hampshire covers only an emergency dental benefit. And actually they only started doing that in this year. So we've got to include that into the data. So in this case, we don't actually know what states people live in, and that's why. All right, so let's talk about Medicare Advantage. Let's talk about this big problem. Medicare Advantage is hot right now. More than 50% of people who enroll in Medicare are going on Medicare Advantage plans. This is the first year that's true. I mentioned before that maybe they're offering some benefits that traditional Medicare doesn't offer. And maybe they're not doing that just because they're really nice. Maybe they're doing it because a younger, healthier, lower healthcare cost population is more likely to enroll in Medicare Advantage. Another important thing to note is that Medicare Advantage also disproportionately serves non-white identifying Medicare beneficiaries. And so as much as I'm being kind of coy about the fact that I think Medicare Advantage has some big problems, it also possibly has the potential to reduce health disparity. Or at the very least, it's really important to know how it works because it could be an engine for worsening or improving these health disparities over time. And there's some question that 94% of Medicare Advantage plans are offering some kind of dental benefit, which we don't fully know what that means. It could be anything. It could be nothing. It's like a big black box because our data didn't cover it.
I think I'm confused. Is this the Medicare Advantage data? Is this also part of the MEPS? Like MEPS takes into account all
Exactly. It includes these folks. The only thing it doesn't do is ask them if they have dental insurance. So it's basically like the person reading the script on the phone to the Medicare beneficiary is like, okay, you got Medicare Advantage. And then it just says, skip the dental insurance question data. So it doesn't ask. So some could, some couldn't. Maybe they don't know if they do. We can't tell. So does Medicare Advantage improve oral health? We've kind of got conflicting results, right? Because on the one hand, people are much more likely than traditional Medicare to be offered a dental benefit. And on the other hand, we have no idea what that is. So let's compare. Remember that graph I showed before with that big drop in the change in private insurance dental coverage? We compared traditional Medicare and Medicare Advantage beneficiaries. And the change is actually larger for the Medicare Advantage enrollees, which means maybe they had better private insurance before they chose to enroll in Medicare Advantage, but certainly they're not continuing to have really good coverage going forward. And in terms of the change in proportion receiving restorative procedures, the jump was larger in traditional Medicare Advantage or traditional Medicare enrollees, but there still was a jump for people with Medicare Advantage. And the change in edentialism, that big jump where people all of a sudden started losing all their teeth, that's the same in both groups. My conclusion from this is that Medicare Advantage may say they're offering a dental benefit, but I don't think they're offering a very good one, or they're not offering one that is widely accessible or utilizable by their population. So in conclusion, reaching Medicare eligibility results in increased edentialism and decreasing utilization, which worsens over time. Let's talk about what that actually means and what we can do about it. So back in August 2021, that New York Times article comes out. Everyone's really excited. The ADA comes out with this, which is a response to the proposal to cover a Medicare dental benefit. There are two parts of this that the ADA particularly thought were inappropriate. The first was including Medicare dental coverage under Medicare Part B. The second was having it apply to all Medicare beneficiaries. And I'll just talk about what those two things are. So Medicare is in parts. Part A is inpatient. Part B is like outpatient services, and Part D is drugs. That's the easy one to remember. But the other thing that means is that a Medicare Advantage plan has to include all of those parts and be equivalent. So by placing it in Medicare Part B, two things are true. One is that every Medicare beneficiary gets access to it, no matter if they're traditional Medicare, Medicare Advantage, doesn't matter, they have to have it. And the second part is it's going to be administered by the people who are administering every other form of outpatient medical care that people get. It's not going to be special or different or distinctive or funded in a different way, which makes it a lot easier to, in the future, integrate it into health. Instead, what the ADA wanted was what they called Part T, which meant a special separate part that was just dental care. That means those two things I mentioned wouldn't be true. Maybe Medicare Advantage wouldn't need to provide this dental benefit, which again is 50% of all Medicare beneficiaries. And also, it's its own little thing, continuing to be siloed, just like it always has. And then going back to the other part, Medicare traditionally has always been an entitlement program. If you are age 65 in America, with very few exceptions, you qualify for Medicare. It doesn't matter if you're really rich, it doesn't matter if you're really poor. And it means that Medicare is very powerful. It can change the way healthcare is delivered, and it usually does it to the benefit of Medicare beneficiaries. If you restrict only to a low-income group, you're making the Medicare dental benefit be something entirely different than the rest of Medicare. And you can imagine whether that's good or bad. So the ADA proposed only including people making less than 300% of the federal poverty line. So this is looking at the change in edentialism for people making 300 to 400% of the federal poverty level. So people who are actually making a fairly robust income relative to the average, some very low income folks that are in this data. And there's still a huge jump in edentialism right at age 65. Keep in mind, this is a population who would not benefit from the ADA's version of a Medicare dental benefit. But I would argue that this data is pretty suggestive that they would nonetheless benefit from a Medicare dental benefit, which shows that everybody needs to have access to dental insurance and dental coverage. This is sort of a hot off the presses part of this. This year, for the first time, Medicare produced a proposal to cover what they were calling like medically necessary dental benefit. And you guys can get in the weeds of like, what does it mean to be a medically necessary benefit? Is that word, are those words we want to use? Are we comfortable with that definition? I actually am not. But what that actually meant is that they were going to start covering just this year dental exams and necessary treatments prior to organ transplant, cardiac valve replacement, and valvuloplasty procedures, which is like, there are not that many Medicare beneficiaries compared to the 64 million Medicare beneficiaries in the country getting these particular procedures. But the ones that do now have some dental coverage. I realize that this is like such a small change. It's like we went from doing no one to doing like almost practically no one, but like maybe a couple of people. But it's bigger than that, right? Because what they're doing is Medicare is going to learn how to pay for dental care. They're going to learn how to do it for like not that many people for a very narrow reason. But then it's going to be set up and built exactly the way Medicare originally proposed it, which is in Part A and Part B, using the same tools they use to pay for outpatient medical care. And so there's a kind of exciting on-ramp for what could this mean next. Does this mean we're going to start covering dental care for all people with diabetes? Or does this mean 10 years from now, we're going to start covering dental care for everybody using the tools we developed for this small population? So that's where we are policy-wise. What are the other questions that have to be answered to help advocate for those policies? So just from my research alone, the things I'm most intrigued by are, what sort of dental coverage does Medicare Advantage actually grant to its beneficiaries? Because keep in mind, we have no idea on the basis of MEPS alone. What we do know is that MA beneficiaries don't seem to be accessing dental care, and they certainly have equal costs out of pocket as traditional Medicare. Other questions I have are, what does the dental utilization reflect in terms of people switching from one kind of Medicare to the other? Are people switching and then able to access more dental care? Are people switching and able to access less, or is there no difference at all? And also, as we see these changes in utilization with advancing age, there's also the question of what do these dental utilization changes imply about how people age and how people age well? Is it just that dentistry becomes less of a priority for people as they get older? Or is it that oral healthcare utilization itself is contributing to developing frailty? So getting older, being weaker, not able to access care, not able to function as well. And then ultimately, Medicare is not covering dental care right now, but it is incurring the costs of omitting dental care. And you can put an actual dollar sign on that cost. That includes things like ED visits or people who are hospitalized for preventable dental problems. But there are also costs sort of on the like higher level of what that means for Medicare beneficiaries. How does it feel to not have dental coverage? What does it mean when you decide to have all of your teeth removed and get dentures? These sorts of costs are not well studied and not something that it's particularly easy to include in research, but are important because they're the things that are most important to our patients. And for the non-students in the room, I do think that there's a pretty compelling research grant path through these sorts of questions to further refine using largely nationally representative data sets. And then eventually, when we wave our magic wand and all work together, evaluating the efficacy of a Medicare dental benefit. I'd really like to see that happen, hopefully the next decade or so. So this is the overall conclusion of my research, which will actually be coming out in Health Affairs on February 1st. Implementing a Medicare dental benefit would improve oral health for millions and reduce oral health inequities among older adults. I have some supplemental slides for the questions I'm hoping people will bring up both on Zoom and in person, but it's really exciting to talk to all of you about this.
There's a wonderful book, Innovation and Its Enemies. Here, the enemy is the ADA.
You said it, not me.
This is related to that. We do a case study on all of this now in our courses.
Awesome.
And so we do to look at it from various perspectives. Students break into roles of stakeholders and then defend their viewpoint to Congress. So this has me thinking about those who played ADA this year. And I don't know if any ADA reps from last year are here. Is a large motivator, right? And for the profession as well. So there was a single figure that stayed with me, and it's that $5 per year per person. I imagine there's some way to anticipate how that would actually benefit the profession, given that such a large proportion of our students' populations will be older adults on Medicare, right? Mm-hmm. So is there financial modeling that can demonstrate that this actually is a benefit to the profession?
Yeah, I mean, it's going to increase the population of people who are able to afford dental care probably pretty substantially. So I think just to clarify exactly what the cost concern is, right? And I don't want to be glib about the ADA tends to be on the more conservative side, change is scary. This is a big change. It would require giving up a lot of familiarity with how we pay for things in dentistry. And I do like understand like those are real concerns. And then part of it is that Medicare has historically paid less than private insurance for various things. And that's totally true in medicine as well. The way it works in medicine is partially different because that's not affecting the bottom line of the typical physician who is usually working in a hospital or a health system that kind of buffers them from those cost changes, whereas the average dentist is very directly affected by how much they're receiving. And those numbers have not been particularly well quantified. I know there's someone in the room who is very capable of looking at that kind of implication for the average dentist. But I think the other part of that I honestly think is sort of more a part of this reactionary fear is the fear of change itself. Because once Medicare starts getting involved in the oral healthcare space, it's not just about how much they can pay dentists or how much they're willing to pay dentists, because I think you're right. From a volume perspective, it would be opening the door to millions and millions of people who cannot afford to go to a dentist, who don't go to one because they, and patient and dentists report, like we know this, that they are generally feel they are underoccupied, that they have capacity for more patients and wish they were busier. But I think the other part of it is that Medicare in medicine can set changes that are very good for patients, but can be very challenging for health systems. This includes things like shifting to value-based payment, to looking at patient-reported outcome measures, to mandating certain quality metrics, to saying things like you have to use an electronic health record. All of these changes, which I think we would all agree are probably really good for all of us when we get our healthcare, are hard to do. And I think for a lot of dentists, that's the part that's scary. It's knowing that once Medicare is in the game, they're going to change the rules of the game. And like my take is like, they're going to change them for good. But I think that even beyond just cost, there's also a fear of lack of autonomy of our like self-organizing profession, which has benefited in very tangible financial ways from its isolation from medicine for 100 years. Yeah.
Simon, I have a similar question because I think that point is very well taken, because whenever I speak to public health driven focused experts in this arena, they focus on the increase of total expenditure and how that will bring in more dollars, which will then really go to the providers. But then you talk to providers, they're like, I'll rather do less procedures that's more lucrative as opposed to get busy all day. But then I think it goes to your point about the fee schedule. My understanding is that the ADA doesn't want to sign up on behalf of dentists onto something without knowing what the fee schedule is. But my understanding of this legislative framework is that the fee schedule would never get developed unless the Medicare part covering dentistry is signed into law itself. So that begs me to ask, that seems like an impossible task, because HHS would never, or like they would, like Center for Medicare and Medicaid would never develop that fee schedule that's to the satisfaction of the average private practice dentist, unless we first agree to sign on to this. And on the same point, when we look at Medicaid data, more and more DSOs are taking in Medicaid patients. And I know like PDS, they are implementing like Epic, like UCSF just implemented Epic. So what do you think might be the danger that you almost hinted at, that I felt like you were also saying some of that self-autonomy is given up once we sign up for something like this? And what can we do to maintain that self-autonomy as a profession, but also pursue all these good things that we know to be true for the patient?
So I don't know if I'm in favor of having us have self-autonomy. Is the short answer. I'll leave you with like two pieces of data for that. The first is that like, let's talk Medicaid, right? Medicaid is the program for low income people. It's administered on a state level. I know it's a repetition, but viral curriculum, we're going to go over it again. It's really important. Mass Health is very generous. Many other states are not. But even here in Mass Health, the amount you get for the procedure you do is substantially lower than you will get reimbursed from a private insurer. And for many dentists, they say it's too low. I'm not going to accept medication. I can't afford to accept medication. But if you look on an XY axis of every state in the country and what percentage of private insurance their Medicaid payments are, and then on the other axis, you look at what percentage of their dentists accept Medicaid, there is no correlation. Medicaid generosity does not correlate with how many dentists accept Medicaid in your state. There's something else going on. There's something about all of us. There's something about our profession that makes us think differently. You could offer a lot more money, and based on that, it would not make people enroll in Medicaid more favorably. There's something else about who we are as clinicians, as caregivers, as community members that makes us choose to enroll in Medicaid or not in our practice. And I think that would probably be true in Medicare as well. The other piece of data I want to mention is that if you talked to doctors in 1963, and they did a lot, Operation Coffee Cup, right? Like people are like playing their Ronald Reagan Speaks Out Against Socialized Medicine records and like pouring coffee for their like fellow wives that don't work. And if you polled their husbands, because they're all men, it's very like heteronormative historical world. And you ask these doctors, how do you think it's going to be in Medicare? People were like, it'll be horrible. The world will be on fire. I will never be able to practice again. Everything is going to be the worst. Like, and truly it was validated. Like they looked at these surveys and people were extraordinarily negative about it. And then they did the same survey in 1968. And people were like, yeah, Medicare's fine, I guess. Things are going okay. So part of this is, I think, what you're mentioning, which is like, we are on that precipice where we're like, it is horrible. Like nothing will ever be okay again. There'll just be like lightning firing from the sky, like constantly in this like terrible world where Medicare provides a dental benefit. And I think that whatever happens, when we finally get there, 5 years later, people are going to be like, yeah, it's fine. I wish it worked better, right? Like I'm sure there will be some like challenges related to it. But ultimately, I think people are just going to like chill and accept that it happens. But getting them to that point, I think will actually require making it not a choice that dentists have, which is, I will point out, exactly what this is doing. This is saying, you don't have a choice. Guess what? We're covering it for these people. We're going to figure out how to do it. We're going to set our fee schedule. You don't get any buy-in. Aisha?
Yeah, I guess this relates to like this initiative or I guess, but like a lot of dentists right now don't accept Medicaid, you know, like that's the generous like promos or promos. So would there be some kind of advice that there or like would it
It's a really good question. And I think the answer goes back to kind of what Adam has mentioned, which is that like, we don't know yet because it doesn't exist yet. And I think you could imagine all sorts of like ways of doing this. So thinking about what this might look like, these vary, like this is probably maybe a couple thousand Medicare beneficiaries who are going to get the benefit. What I think will happen is that this is going to be folks going to like the oral medicine clinic at the Brigham, which already knows how to bill medical insurance, which already bills Medicare all the time. You're talking about like very small number of dentists who are already affiliated with a tertiary care medical center who sees patients like this. The average dentist is not going to be like, oh, well, you're getting a cardiac valve replacement. Like, let me learn how to register for Medicare and become like certified and get my PICO certificate. Like there's so many steps. Like that's, I think the average person, this is not going to affect. But on the back end, Medicare is learning how to do it, right? And part of that is going to be, maybe they're deciding how much they're going to pay for a filling. But what I suspect they're actually doing is figuring out how they want to pay for what dental care might be, which may be very different than a fee-for-service. Medical care is not administered or paid for in a fee-for-service system. And I'll just say briefly, like Medicare reimbursement, while low, definitely preferentially overpays subspecialists. Like the average orthopedic surgeon is paid much more generously by Medicare than the average primary care doctor. And there are a lot of big problems from that. But it's all done through something called the RVU, the relative value scale, which is like a group of people who come in and they like secretly like kind of lurk and decide how much relative value various doctors give and various procedures give. Which like many dentists have been like, we can't possibly be on the RVU scale. And it's like the point of the RVU scale is like anything you do to a human body can be put on the RVU scale. And you can disagree with where it goes, but you absolutely can. So what I actually think is going to happen is like whenever Medicare busts out with a plan that covers more than a couple thousand people getting aesthetic surgeries, it's going to be in a way that either is you're part of an ACO, the quality metrics involve whether people get access to a dentist, the money we give you to take care of people overall needs to in part fund their dental care, you figure it out. Or here are the RVUs for dental care. And then like, that's going to be how we reimburse. I will note, super scary to dentists, like the ADA is terrified of this, but you can imagine ways in which not being paid for the procedures you do makes your like satisfaction with your work way better. Because I don't know about you guys, but like calling patients to see how they're doing, checking in, if they call you with questions, if they want to like talk about a procedure again before they do it, those are all in our current system, totally unremunerated. But I think they're really important for being satisfied with how you take care of people. And you might imagine that shifting to a quality-based system could actually meaningfully reimburse you for that time in a way that makes you more likely to do that, but also makes you less frustrated that it's 9 p.m. and you're sitting in your pajamas on a patient portal responding to a patient, because you feel like it's part of your job and that you are like paid for it to be part of your job. So I think that this is not just a benefit to the population, but also to us.
So what do you think is going to happen with this question 2 and Delta Dental?
Do you guys know what question 2 is? How much it has to do on question 2? So it's not here, but like I would put like what happens with question 2, like right into that R path. I think that's, I have a reminder on my to-do list that on January 1st, 2025, I should start assembling the R to look at what happens with question 2. Because I don't know. So question 2, medical loss ratio, right? We're also happy question 2 passed amazingly in Massachusetts. It passed with like the largest margin of any of the questions, even though like there was a literal millionaire's tax and like they barely did. My husband is a doctor. I was like, we should get a question 2 sign. He's like, Lisa, we should get a question 1 sign. Like, what are you talking about? But anyway, so medical loss ratio, and Adam, I remember you asking me about this back last year when you were in the health policy course, is something that's very well established in medicine. Like we know it works. We know that it helps decrease the cost or decrease the increase in the cost of care, and is probably better for both individuals and also kind of just modulates insurance plans. And we also know from California that there is just a crazy range of medical loss ratio in dental plans. Like it's everything from like 23%, which is like super not okay, to like kind of above the cutoff we set in Massachusetts, which is 80%. Like I think one plan had like an 83%. So I think it's really unknown what's going to happen if we all of a sudden standardize all of those. I suspect that what is not going to happen is I don't think that individual patients are going to save any. I think dentists might make a little more money. I think cost transparency will occur, but I don't actually think we're going to see a direct consumer benefit. What that will actually look like in terms of how utilization changes and what the rates for different procedures are, I'm not sure, which is why I look forward to studying it once there's a couple of years of data. Because there could be a world where patients actually pay more, right? If people increase the cost of each of their procedures, which insurance companies will be happy if they do, because it will allow them to increase their medical loss ratio, then patients who don't have insurance will have a higher price for that billing. I think all of this goes back to, is fee for service the way we're going to be doing things forever? It doesn't really seem like the best way to do things, but this might be more support for that based on what happened.
As we move toward more universal health coverage around the world and in the United States, just curious if you think some of the lessons learned in other countries, like in Japan and Thailand, where they have type 3 and they have implemented dental coverage and have policy 80 years old, or will have 20. Do you think that there is research that has been done that could influence how we look at things here in the US?
Yeah, so I want to just put a plug in for Ichiro Kawachi and Hawazin Alani, who are HSDM folks, are doing really cool regression discontinuity modeling, looking at Korea's dental benefit system. Off the top of my head, I would have to like pull up the abstracts, but they've interestingly found what they really looked at is like people losing their teeth, like they're like my line in the sand was age 65, their line in the sand is losing, or rather Korea's dental benefits starting to cover dentures. And they've only had a couple years of data, but I've been surprised to see that the changes in health outcomes and even in chewing outcomes have not actually been that dramatic. My suspicion is that dentures are really good at replacing no teeth. They're really bad compared to teeth. We may be looking at like a downstream effect, right? Like when I talk to doctors who don't know anything about, the physicians are about, and people don't know anything about teeth. They're like, is it bad? Is dentalism bad? Like, what does a dentalism even mean? And I'm like, well, it's sort of like mortality for dentistry. And like, which is to say that like, sometimes maybe it's not bad, right? Like maybe if you've had like horrible toothaches and you're suffering a lot, getting dentures can be transformative for you. You might have teeth that like allow you to feel proud and fit into society in ways that you didn't before. It's probably a lot better than chewing with painful teeth. But the fact that you got there in the first place means that like a lot of things happen that tell you about your whole life course and your life trajectory. So I think like even just looking at like that moment, that inflection point of getting dentures, like it's a blunt instrument. So I don't know what overall it will look like. I suspect that Hawazin, who is a really brilliant researcher, is already thinking about it.
There's a few questions on the Zoom.
Oh,
I don't know if
fantastic.
can you see them or would you like me to read them?
I can try pulling them up. Oh, and fail. All right. The extent of dental coverage on overall Medicare costs. Can you link MEPs to Medicare claims data? Compare costs. Yes, so that's a great question in terms of actually looking at Medicare Advantage. And we have done some of that, right? Because we're able to, all of the cost data is validated for Medicare and Medicare Advantage. And we can see that there's actually equivalent costs, there's equivalent out-of-pocket costs, which I think is going back to that question. And then there are also other nationally representative data sets that are probably better for looking at this question. And the one I'm most interested in is the Medicare Current Beneficiary Survey, which has a very descriptive name. It is of current Medicare beneficiaries and does a better job of therefore pulling apart Medicare Advantage and traditional Medicare beneficiaries to look at this sort of thing, the overall cost. The last one was made, the consolidation of dental practices by DSOs into large groups will eventually open the door to accepting a fee schedule that will change the current posture of the profession. I completely agree. Medicare were to provide dental coverage, do you expect there'd be a federal mandate requiring dentists to accept Medicare? I think the answer is we don't know. There is no such mandate for Medicaid, but it's not working very well. And in general, within the medical system, there are some requirements to ensure that Medicare is widely accepted, but the few physicians who are still kind of working in a dental-like model where they like hang their shingle in their private practice are not required to accept it. So I don't think that it would all of a sudden be a broad mandate. I think there would probably be some very interesting carrots and some very interesting sticks to figure out how we could scale up Medicare dental. I think the one thing to say is that this will cover 65, if there is a Medicare dental benefit, it will cover 65 million people who are the highest utilizers of dental care, older adults with high dental needs, the heavy metal generation. I don't think we're going to need to mandate that dentists have to accept it. I think that they're going to have to because it's such a large representative patient population. And I think that a lot of dentists are aware of that too. I think that's where some of the spread is coming from. It won't take a mandate. The mandate is it's going to cover so many Americans. The last one, their comment. In 5 minutes, I think we're already seeing that acquisitions of DSOs by healthcare organizations. And I'll just put in a plug that like here in Massachusetts this year, for the first time, there are mandated adult medical, dental quality metrics within the Mass Health ACO. So we're already seeing medical ACOs or like medical insurers be on the hook for dental outcomes. I would encourage folks in the chat to continue to include questions, and I would love to keep answering them. I'll just keep an eye on that. But I'll close this.
We did some work at one point with Medicare Advantage plan, you recall this, where they attempted to integrate a dental practice into one of their primary care centers because the beneficiaries really, really wanted more access to dental care that they could trust. And they had difficulty making it work. But just having heard how much the beneficiaries do wanted to have access to dental care, I was surprised during the Build Back Better effort that there was not more from the consumer, from the public, about this being important to individuals and something that people really want. Do you have any thoughts on why we hear more from the public on the importance of dental benefits?
And within the Build Back Better situation, I think like there were so many other competing priorities. Like I think that made it really difficult. Like, you know, people are being asked, like, do you want to focus on like a child care benefit? Do you want to like their ongoing vaccination efforts? Like I think it was just a very distracting time. But I think the bigger question is, why are we so bad at advocating for dentistry? Like, why isn't it talked about the way other forms of health injustice are talked about? And I think that there are a lot of reasons. Like one is that by being separate from medicine for the last 200 years, like we've built the silo, like it's us, we did it. And it has financially benefited the practice of dentistry such that breaking it down to be more a part of those conversations is not something a lot of dentists want to do. So you get like just a few like non-mainstream lefty dentists, like the ones in this room who like really want to do that talking. I think the other part of it is that separation has made oral disease something that people experience an unprecedented amount of shame and stigma about. I would probably compare it to things like the current sort of substance use disorder advocacy movement or like the opioid crisis advocacy movement, where there had to be just a huge number of deaths and a lot of work to dismantle that stigma in order for people to be able to talk about their lived experiences. And even now, like that's really difficult. So finding patient advocates who are willing to say like, I lost all my teeth. This is how it felt. I lost them because I couldn't afford not to. Like, that's not something that we're like equipped to have happen on a national scale. Even like often for like state level policy initiatives, there's goals to like collect patient stories and find patient advocates. And it's hard. It's really hard because people don't want to talk about this. They still feel like deep down it's their fault, or they did something wrong, or if they just brushed their teeth, they wouldn't have this problem. Instead of talking about it as like a structural injustice, the way we talk about other forms of health inequity. I think that's that needs to.
The other night, Massachusetts, the only state that has a Mass Medical Society Committee on Oral Health. And we heard from Healthcare for All, putting together a commission on oral health that has about 6 zillion people, 1,200 organizations.
Yeah, it was pork barrel funding. They like snuck it into another bill. I was very excited.
Unbelievable. And one of the things we discussed was the possibility of the old suggestion by Richard Mansky to have a moratorium on regulations in the state and let medical students learn oral health and dental students learn general health and take away the restrictions of licensure during at least learning. What do you think of that?
I think that's great, but I think if people learn those skills and they go off and practice in a world that doesn't empower them to keep using them, they're not going to remember them or feel empowered to use them.
How do you keep them using?
That's a tough question. A Medicare dental benefit would probably help. I mean, I think like, I'm being glib, and I know I'm a physician and a dentist, but I also haven't picked up a handpiece since like March 2nd, 2020. So like, I think about it sometimes, like, could I pass a summative? Like, probably. Would you want me to do your dad's filling? Like, definitely not, But I think there's this question of, is integration something that people do, or is integration something that systems do? And I think the answer is hopefully both, but probably the systems need to first, or more important. Like, maybe we don't need a physician that knows a lot about oral health. We definitely need a physician that knows that a dental benefit exists and can seamlessly communicate with a dentist. Like, thinking about, I have patients who have ophthalmologic concerns. They're having really complicated ophthalmologic surgeries. You can see the words I'm using are very vague because I don't know anything about eyes. Like, you can't, if anyone's seen the ophthalmologist note, it's like written in Latin. Like, it is impenetrable to me as a primary care doctor, but I don't need to know it. I don't need to have shadowed an ophthalmologist doing a retina surgery to be able to facilitate my patient who needs a retina surgery getting the retina surgery. We need a system where insurance pays for that, where I can send them a referral, where I can get a closed loop communication that the patient got that surgery, and then I can continue to follow them up. So I think part of it, and like, it is good that I know that eye doctors exist, right? Which I think for many physicians is not something they're aware about in dentistry. Like, it's good to have a little bit of awareness, but I think that it is about a system of integration that works for people, because I don't think we can expect everyone to be a one-stop shop.
Question.
Always. I mean, like for 5 more minutes, then by email with me.
The way, like, I'm trying to frame my words in a way that I'm not like, I'm being like neutral.
You get class, go for it.
I think the way that you were talking about it, in the sense that with the 1965 Medicare before and after in doctors' attitudes, the way that you were framing it seems to me that we are almost like, it will probably happen the next decade, if not the next decade after that. And I don't think there's enough criticism about regarding what that could do to us as a profession. For instance, like when you said about value-based care, I think value-based care is great. It's at least as good, if not better, than fee-for-service, which medicine already has. But at the same time, there are a lot of things I don't like about medicine. For example, the consolidation of big hospitals. When faculties talk to us about like this surgery being done in that hospital, they're like, oh, by the way, they all combine into one. They're just one now. Like, that to me is not good for consumer choice. And that's kind of, to me, how providers decided to gather together to fight other big players. And that is not something potentially that's like just inherently good for our profession. At the same time, I also don't think the subspecialization within medicine is what I want to see either dentistry. For example, right now, the specialists, as many as there are in our school, that's the exception. Most people are going to general dentistry. But I think if we adopt a fee schedule that essentially prioritize specialty services, then we're going to see the same problems that we see in medicine, where people do not want to go into primary care. So I think there are a lot of lessons that we can learn through that transition of medicine, where I just don't feel like we should sit on our butt and kind of like watch it happen, especially in the context of our increasing student loans. Like, for example, like no offense to the DSO comments, because I don't think DSO itself is inherently good. It could be good. Like, I think they're better suited to pursue value-based care than one private practice office. They're better at getting Epic, integrating medicine. So I kind of want you to like tell me more about concerns regarding what we can do to make sure that we don't turn to medicine all for the same problems.
I think there are a lot of interesting questions there. I think we should talk offline about a lot of those points. But the big picture I'm going to say is what you're saying is you want to get into the policy weeds of how to do this right. And what organized dentistry has done instead is said, no, 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 no. And it means that we're not at the table. Guess what? Medicare doesn't care about your concerns. They figured out a way to do it without us because we made them. We like took ourselves out of the game. That is what comes from sort of an irrational reactive fear to this sort of change. If we actually want to drive the ship, we need to show leadership, which we're not effectively doing at the moment. So, I mean, obviously there are like a couple of dentists who are really interested in this and like publish policy on it. But like the average dentist in their private practice, or more realistically, the average dentist who is an ADA member and feels like the ADA has their best intentions at heart, is probably not being well done by the ADA universally and unilaterally opposing any progression in oral health policy. Because it means any progression in oral health policy is external. And I think that is exactly what you're describing.
All right, that was a really long-winded way of saying, right now our advocacy is pretty good at saying no, but we're not providing alternative solutions that would be mutually beneficial to the provider.
Yeah, it sounds like we need more research using nationally representative data to better understand the implications and how we can model them. I agree with you.
That's a perfect note. And Don, we need more research. That's what we're good at. So Lisa, thank you so much for a very thought-provoking and engaging presentation. And thank you all for your questions and participation today.
Thanks, everybody.